This is old data from before modern therapy with statins and hypertensives and aspirin and things, showing the sort of background of if you're diagnosed with type 2 diabetes in your 40s, you're going to die 10 years earlier than your friend next door at the same age, to stress the problem. Now, in terms of glycemic medications for cardiovascular protection, as we heard earlier, we had a slow start, but now things are accelerating, and it started with metformin in 1998, showing cardiovascular protection for metformin. 10 years later we got pioglitazone, and then we had to wait, 7 years later pioglitazone, we had to wait another 10 years for Empareg last September, and then in June of this year we got liraglutide from Ryder, and now just this time last Friday actually, a presentation of Sustain 6 with semaglutide, so we have a lot of glycemic agents now associated with cardiovascular protection. This is a slide from the actual presentation in 1998 of the UK PDS, which showed that metformin given to overweight patients was associated with a reduction in mortality and myocardial infarction, the only agent in the UK PDS to be demonstrated to have cardiovascular benefit. There was a 10-year follow-up to the UK PDS in which the separation of the lines, metformin lower death and myocardial infarction, and is often pointed out that it took 3 years before the lines started to separate in the UK PDS. But of course these were patients who were followed from diagnosis of diabetes, unlike the other cardiovascular outcome studies where they were all patients who already had cardiovascular events, so much later on in the disease. For the cardiovascular outcome studies I'm going to mention now, which followed the FDA instructions that cardiovascular safety studies must be undertaken, they all have this combination of things that they look at, measuring the combination of death, myocardial infarction and stroke, looking to see is death, myocardial infarction and stroke less with the agent than with placebo. And the studies that are positive to date are all the so-called 3-point MACE, the death, myocardial infarction, stroke data for each of those studies shown here with the therapy, the lower line, significantly below the placebo, the upper line in all the studies. So if we start with pioglitazone from Proactive in 2005, an overwhelming amount of data, but I'll start with each one so that to tell you what I think the conclusion is and then show you the evidence. So I think the accumulated evidence suggests that pioglitazone reduces cardiovascular death, myocardial infarction and stroke by slowing down or even reversing the atherosclerotic process. This is if you have a myocardial infarction and you're given pioglitazone versus placebo, you have a significantly reduced chance of having another myocardial infarction. Even more so for stroke, if you've had a stroke, a considerably reduced chance of having another stroke if you're pioglitazone versus placebo. In a randomized controlled trial, pioglitazone slowed progression of carotid artery intermedia thickness, which is a marker of coronary atherosclerosis, compared to glimepiride. Pioglitazone treated patients showed a significantly lower rate of progression of coronary atherosclerosis as assessed by intravascular ultrasonography compared to glimepiride. In the meta-analysis of randomized controlled trials, 19 randomized controlled trials, there was a significant reduction of death, myocardial infarction and stroke compared to patients given control therapies. And finally, from this very year, as we heard earlier, we have the IRIS trial in which pioglitazone was used in patients who didn't have diabetes. They only had insulin resistance, but they had a history of stroke or TIA. And in that group of patients, the risk of having a stroke or myocardial infarction was reduced by 24% in patients who received pioglitazone versus those who received placebo. So I hope you're convinced from that data that the accumulated evidence suggests that pioglitazone reduces cardiovascular death, myocardial infarction and stroke by slowing down or even reversing the atherosclerotic process. If we go now to this time last year, the EMPA-REG study, this trial suggests that empagliflozin reduces cardiovascular death but does not reduce either myocardial infarction or stroke, signifying a different mechanism to that of pioglitazone, more hemodynamic in nature. And this is the 3-point MACE data showing empagliflozin causes less combination of death, myocardial infarction and stroke, but it's driven by the considerable reduction in cardiovascular death. And if you look at the individual components, that's the 3-point MACE, just statistically significant, whereas the cardiovascular death is massively reduced and the myocardial infarction and stroke aren't significantly reduced. So the 3-point MACE is driven by less death. And one of the things to note is the separation of the lines, which occurs almost immediately with the empagliflozin, whereas there's a delay with pioglitazone, perhaps while the atheroma gets less and less. And people have pointed out that the rapid separation of lines is similar to a study with the diuretic eplerenone in patients at high cardiovascular risk, looking at heart failure, and the heart failure and death are reduced, but immediate separation of the lines. And if you've got heart failure in the EMPA-REG, immediately the empagliflozin group have less. And of course one starts to remember that empagliflozin causes a diuresis, it causes glycosuria, so maybe that's the mechanism. It's also been pointed out that empagliflozin is associated with ketogenesis, and there is data to suggest that ketone bodies are a more efficient fuel source for the failing myocardium than glucose, so that is another possible mechanism. So the trial suggests that empagliflozin reduces cardiovascular death but does not reduce either myocardial infarctions and stroke, signifying a different mechanism to that of pioglitazone, more hemodynamic in nature. So if we come to LEADER, liraglutide, presented at the ADA in New Orleans in June of this year, again 3-point MACE reduction, and the LEADER trial again shows a bigger impact of liraglutide on cardiovascular death and on stroke and myocardial infarction, but in contrast to empagliflozin, shows no impact on heart failure. This suggests different mechanisms for liraglutide to both pioglitazone and empagliflozin. So this is the cardiovascular death reduction in LEADER, and the 3-point MACE data side by side, and again some delay with liraglutide. I think there probably is an impact on atherosclerosis, but I think there's also other things going on with LEADER. So we have the cardiovascular death more in empagliflozin than liraglutide, but still striking that the death is much more than the myocardial infarction and stroke in LEADER, suggesting perhaps other mechanisms than just reduction in atheroma. And this is to show that the liraglutide doesn't impact on heart failure, whereas empagliflozin does. So in conclusion, again, the LEADER trial again shows a bigger impact of liraglutide on cardiovascular death and on stroke and myocardial infarction. But in contrast to empagliflozin, no impact on heart failure, suggesting different mechanisms for liraglutide to both pioglitazone and empagliflozin. So is there potential for these agents to complement each other? If we have them causing benefit in the area of cardiovascular disease, as we've concluded by different mechanisms, and so they might just be complementing each other anyway, but possibly if we look at the side effects of these agents, pioglitazone, fluid retention and weight gain, and I note weight loss for empagliflozin and liraglutide, genital infection for empagliflozin, and GI side effects for liraglutide, if we remind ourselves that empagliflozin reduces heart failure, could it be that it offsets the fluid retention of pioglitazone? And could it be that the weight loss of empagliflozin could offset the weight gain of pioglitazone? And indeed, at the same ADA in June of this year, there is now evidence to suggest that the fluid retention and weight gain associated with pioglitazone is mitigated by an SGLT2 inhibitor. This was actually canagliflozin, but nevertheless, I think you get the message. And there's also the weight loss of liraglutide. Could that also contribute to offsetting the weight gain of pioglitazone? And there's this very important landmark paper from Ralph DeFronzo's group, which, following on from his famous ominous octet that we heard about earlier, he did a trial looking at early intervention, comparing when the patient presented with diabetes, immediately giving them the combination of metformin, pioglitazone and the GLP-1 receptor agonist in combination, compared to the traditional approach of sequential escalation through metformin, then add sulfonylurea, then add insulin. And he demonstrated that the early use of this triple therapy aggressive approach lowered hemoglobin A1C more, caused much less hypoglycemia, and there was overall weight loss, whereas with the traditional approach there was weight gain. And so we have demonstrated in a clinical trial that overall, if you mix pioglitazone and a GLP-1 receptor agonist, you get overall weight loss. So our conclusion, and this paper from myself and Ralph DeFronzo is online ahead of print in the British Journal of Diabetes at the moment, and if you search for Google Ryder, DeFronzo and Leader, everything I've just said is in that paper. And it concludes that the combination of metformin, pioglitazone and empagliflozin and liraglutide now appears to be the optimum cocktail of medications for improving both glycemic control and cardiovascular outcomes for people with type 2 diabetes at high cardiovascular risk. The evidence we have today suggests these agents in combination may complement each other to prevent cardiovascular events and save lives. That's me done. Thank you very much.